start. So let's start. First case, Dr. Irene. It is a female, 31 years old, presented with headache. Okay?
Yes, sir.
Female, 31 years old, presented with headache. I will give you 2 minutes, then we are going to start the case. Okay?
Sir, name of the patient?
Call it Miss Sarah.
Okay, sir.
Okay?
Okay, sir.
Okay, Dr. Irene, are you ready?
Yes, sir. Yes, sir. Can I start?
Oh, okay, let's start.
Okay. Hello, I am Dr. Irene, one of the physicians in this hospital. Are you Mrs. Sarah, 31 years old?
Yes, doctor.
Mrs. Sarah, I'm here to talk to you and examine you. Is it okay with you?
It's okay with me, doctor.
Ms. Sarah, I have gathered knowledge that you are suffering from headache. Can you tell me in details, please?
Well, doctor, over the last, I think 8 days, I start to feel this pain in my head, doctor. I don't used to have such a headache. It is not occurring for me with me frequently. This is the first time for me to encounter such a headache.
It is for last 8 days.
Yes, doctor.
Okay, and the nature of the headache, it is throbbing, it is dull, aching, or what is the nature of the headache?
Well, I am not sure, doctor. It's just maybe sometime aching, doctor. Dull aching.
And if I say the which part of the head you are feeling more painful, right side or left side, which part of the side?
Well, I feel it more behind my eye, doctor.
Behind your eye. Okay. And if I say 0 is minimum and 10 is maximum, what will be your grading?
I think 4, doctor. 4 to 5.
4 to 5. And it is your first time.
Yeah, yes, doctor. First time.
Okay. Do you feel that you can't tolerate you have photophobia, like you can't tolerate the light, you can't tolerate the noise?
Well, yes, doctor. I don't notice that there is a difference.
There is a difference.
There is no difference.
Oh, there is no difference. Okay, Miss Sarah. And if you touch when you're chewing and when you swallowing, there's painful on the jaw.
No, doctor.
And there's any pain on a face.
On my face?
When you
No,
touch,
no, doctor.
okay. Do you have any visual disturbance, Miss Sarah?
Well, yes, doctor. I feel like my vision is slightly blurred on my right eye, doctor.
On your right eye. And if I say, do you feel any double or bumping object?
No,
Or
doctor.
only blurred?
Only just a blur.
And there's any condition in your eye, like any redness, any pain?
No, doctor.
no pain, only blood you see, and your vision is only right side, is it?
Yes, only on my right side.
Okay. Miss Sarah, Mrs. Sarah, I want to know, do you have any past medical condition that I should know, like uh, any history of previous medical condition?
No, doctor. I have not been diagnosed with any chronic disease or illness.
Okay. Any past any hospitalization before?
For hospital admission?
Yes.
Yes, doctor. I have been admitted to the hospital. I think 1 years back. I developed this weakness over my left arm, doctor.
Okay. Left arm weak. And what was the cause? The doctor said any diagnosis for that? Is it
Well,
what was the cause?
well, doctor, they didn't inform me clearly what the problem or what the issue was happening with me, but I recovered a lot, doctor, and currently I don't have any weakness over my left arm.
Okay, and is it was 5 year 1 years back,
Yeah, 1 year back.
and is it was associated with headache?
I don't remember. At that time, there was a
Remember?
headache.
Okay, okay. I'll talk to you and examine you. I'm seeing the visual at first. The vision. I want to see the vision of the eye.
Okay, it's
Visual
reduced.
acuity.
Visual acuity is reduced.
Okay, I want to see the any fundus examination. Is there
No
acute
need.
pupil edema? Okay. Okay, I want to see the vitals, BP and blood pressure, pulse.
Normal. Normal.
Okay, I want to also.
2 minutes remain, doctor.
Okay. Do you have any chest pain?
No, doctor, I don't have any chest pain.
Any cough?
No, doctor.
What about your water work?
It's okay.
Any frothiness, any color change?
No, doctor.
Do you have what about your back passage?
What? Sorry?
Back passage. What are your bowel habit?
It is normal, no change.
Any stroke, hardening and losing stool?
No, it is normal, doctor. I didn't notice any
Okay,
change.
Miss Sarah, do you have? I mean, I want to ask some personal question. Do you have any long-term relationship?
Yeah, I'm married, doctor.
Okay, do you take any oral contraceptive pill?
No, doctor.
Okay, do you have any joint pain?
No, doctor.
Okay, any rash all over the body?
What? Sorry?
Any rash all over the
No,
body?
no. I don't have any skin rash, and 1 minute remain, doctor.
Okay, what is your concern, Miss Sarah?
What's wrong with me, doctor? What's happening to me?
Okay, Miss Sarah, after talk to you and examine you, there's some possibility in my mind, but what I will do, I'll do some investigation, and after getting the result, I will arrange another meeting with you for management purpose. It may be the condition that you are suffering from a condition. It's called um, hemiplegic migraine, but for my specific diagnosis, I want to do some test, or it may be any soreness of your blood channel which supply over your head and over your blood channel of the eye. Okay.
Okay.
Okay, is it okay with you?
Your time is finished, doctor.
Okay.
Examiner question. What's your differential for this case, and what's your diagnosis?
At first, my differential was trigeminal neuralgia and hemiplegic migraine, and my other differential was multiple sclerosis, but only there was weakness 1 year ago and visual disturbance. So it was my differential, sir.
So your diagnosis.
I rule out vasculitis. I want to rule out any other
So
possibilities
again,
in my
your
mind.
differential are, the second one is MS, the first one is
Hemiplegic migraine, sir.
hemiplegic migraine. Okay. Why did you say it could be an MS?
Sir, there is a visual disturbance. There's a weakness 1 year ago, and I didn't examine the neurologically, sir.
Okay. If it is MS, what could explain this visual disturbance? What we call it? What is the name of the condition that affect the eye and in the patient with MS?
If it is, sir, didn't get the question, sir.
It is what? Sorry?
Hello?
Yes, yes.
Sir, I didn't get the question, sir.
It is Cushing? Sorry, I couldn't hear you.
Sir, I didn't get the question. What
Okay,
you're asking
okay,
for?
okay, okay. If this, you said the second differential could be an MS, I'm right?
Yes, sir. Yes,
Okay.
sir.
What we call the condition that is very common with the patient with MS and affect the eye.
Okay. It's
Okay, doctor, how you are going to investigate this patient?
I want to investigate it at first. At first, I want to do the basic investigation, CBC, ESSCRP,
Okay,
and
definitive investigation. Okay,
definitive investigation. Specific. I want to see the MRI of the spinal cord and
okay,
for
if
the
it is
brain and spinal cord.
okay,
Yes.
if it is MS, what are you going to do for this patient? Sorry.
Sir,
sorry,
yes,
Dr. Irene, your time is finished. I'm so sorry, but your time is finished.
Yes,
overall, you did very well. The only thing that I think you have to work on is just try to be more faster. Speed
yes,
up your question. Try to move more in a fastest way than what you are currently doing, and you are going to get the diagnosis. You are so close to the right diagnosis. I'm going to explain it for you right now. Okay, just a simple comment regarding your performance. You forget just a few things. You forget the drug history, you forget the family history, you forget the social history, and you forget to analyze the system of the current symptom, which is the headache, and in addition to this patient has a visual disturbance. You should also ask for the other symptoms of the CNS. Okay? That is all. If you just speed up your question, if you move quickly, I think you was able to get the right diagnosis. This case is not an easy case. It is the data or the positive data in this case are slightly not that informative to get the right diagnosis. But overall, you did good. You are so close to get the right diagnosis. Thank you, Dr. Irene. And
yes,
leave your mic is open. If you have any question, I'm going to tell you the right diagnosis. Okay.
Yes, sir. Okay.
Okay. Aside from the comment which I already gave to Dr. Irene, any one of you has any comment regarding her performance? Hello, everyone. Hello.
Hello.
Yes, Dr. Salah.
Yes, Dr. Ala. Yes. I think that Dr. Irene missed to ask if there is any morning sickness associated with this headache or not.
Okay. Yes.
This is
very good
and
question.
Also forget to ask if there is any history of blood clot or miscarriage or not. Also.
Okay. To exclude
the cavernous sinus thrombosis.
Okay.
Yes.
Good. Any other comment? Please open your mic and share with us your comment and your feedback. If you have any comment regarding her performance.
Okay, Doctor. Ask about headache associated with increased intracranial pressure. Which
This is the same point, Doctor. Thank you, Dr. Said. This is the same point already mentioned by Dr. Salah. Huh?
So I think oral contraceptive pills should be asked in this case.
Sorry, Dr. Tanzil, your voice is not clear. Can you please raise your voice?
I think oral contraceptive pills should be asked.
She asked about the pills.
Oh,
okay.
I think, Dr. Ala, for the cases of headache with blurring of vision, it's better to start to do fundus examination for the patient, because she offered.
Okay, she offered it, and although it can be very In some cases, it can be very important. In this case, it was also important, but the possibility to be negative is very high. This is why I asked her to stop it, but she offered it already. The different, I got your point, Dr. Khalid. You are suggesting to start the examination with fundoscopy. Okay, you are right.
Yes.
In some cases, but the issue, as we are going to see later on, the differential diagnosis of headache is very, very long list and very wide range of the differential diagnosis. So it is not usual or it is not a mandatory rule to start with fundoscopy. This is something will be leave to your judgment or based on your case in the exam to offer what you think will be the most appropriate or relevant or the most important investigation. I should start with it my examination. But we can't make it as a rule. Okay, Dr. Khalid? I am going to show you later on why we can't make it as a fixed rule. Okay, any comment? Any other comment?
Hello.
Yes,
hello.
yes, Dr. Shaza.
I didn't hear her asking about high body temperature or weight loss.
Yes, general question. We are going to talk about that also later on. Okay. What else?
Yes, Dr. Ibrahim.
Yes.
Let me ask about social history and the impact of headache on her job, and daily activities.
Yeah, she forget the social history, the drug history, in addition to the family history. The whole social history, the job, the smoking, the alcohol, the impact of the job on her activity or in her life.
Hello?
Yes, Dr. Nazik.
Yes, Dr. Ala. I think if there is more analysis for the symptom of presenting complaint, it will be better to reach diagnosis from the start.
Yeah.
Like if there is any nasal stiffness, if there is any tearing, symptom also of migraine, symptom of paroxysmal hemicrania, if there is any previous attack,
okay,
and the duration of each attack, it can have more.
She asked most of the questions related to the headache, but the issue she was not asked them all. She was not asked them in speed way. Yani she was speaking in very slow way. She didn't ask the question in a fast rhythm or in the fast way, so she can proceed as fast as she can among all the point of the history. But she asked or she analyzed the symptoms of the headache in a good way. We can say that. Okay. The diagnosis.
Okay. Also, tension, about any tension or any stress in the life, maybe tension headache.
Yeah.
Or analgesia overuse headache.
Yeah, that's right. That is right. If she
And
asked
also,
about
I think,
the medication history. Sorry, doctor.
History of trauma.
History of trauma, yes, one of the general questions that you should always ask them. I'm going to explain for you all the proper way to approach the case of the headache, and but I'm going to leave it later on after we finish all the cases of the headache. Right now, I'm going to talk about this case. This case is a female, 31 years old. The positive data was she had a headache for the last 8 days. In addition to that, she had a past history of weakness and history of admission to the hospital, weakness over her left arm. As you can see, this is a neurological case. And when she analyzed the headache, I told her that this headache behind my eye. In addition to that, I had a visual disturbance. The right diagnosis here was an optic neuritis. The one important question she forgot to ask me about, if you think about optic neuritis, you have to ask about the difficulty in color vision, okay? Because in some patient, it could be a positive. Usually, the visual disturbance in the patient with optic neuritis, it is greatly vary between the patient. There is a great variation between the patients. Some patients, they may just have a blurring. Some patients, they may have no perception of light at all, complete blindness. Some patients who have just a blurring of vision, they may have also difficulty to differentiate between the colors or color blindness. In addition to that, they will have 90% of the patient, they have a headache the site of the headache usually behind the eye. This type of headache usually present in 90% of the cases with optic neuritis. The important question here in the history, number one, you have to analyze the headache. Number two, you have to analyze the visual disturbance. Number three, you have to analyze the other, or you have to ask about the other symptoms of the CNS. Then you have to ask about the past medical history, family history, social history, drug history, in addition to the female history. How can we explain optic neuritis for the patient with optic neuritis? How we can explain it to the patient? Optic neuritis, usually there is an inflammation or soreness in one of the nerve behind your eye. Okay. Usually the patient with optic neuritis, they need an admission. Why? Because we are going to give them the treatment of optic neuritis. Usually we are going to give them intravenous methylprednisolone for 3 days. After that, they can take corticosteroid, oral corticosteroid prednisolone for 11 days, or let's say for 2 weeks. Usually the patient of optic neuritis, they recover over few weeks, they return to the normal. The issue with optic neuritis, they may have a multiple sclerosis. This is why they may need an MRI, and if the MRI confirms that this patient has a multiple sclerosis, the patient may need to start as early as he can the disease-modifying therapy. Okay? Usually the diagnosis of optic neuritis is the clinical diagnosis. It's a clinical diagnosis. The most important thing in the investigation, we have to offer to examine the fundus. In the fundus, 30 to 40% of the cases, they may have a swallowing optic disc. Some patients, they may not have the swallowing optic disc. And one important thing I have to offer it in the examination, I have to check if this patient has relative afferent pupillary defect, because it's one of the feature or one of the clinical findings you can find it in the patient with optic neuritis. I have to check the alternating light reflex to see if the patient has relative afferent pupillary defect. All those findings, you can, it can present in the patient, and in some patients they can be negative. Okay. Treatment of optic neuritis, we mentioned it. Differential diagnosis usually depend in your case in the exam. The differential of optic neuritis, it's very long differential. It can be uveitis, it can be some other cause of ischemic optic neuropathy similar to giant cell arthritis. It could be optic atrophy. The differential depend usually in the exam according to your scenario. In this case, the diagnosis is only one thing, which is optic neuritis. Remember in the exam, in the mark of the differential diagnosis, if, especially in station 5, if you get the right diagnosis, they are going to give you, in most of the cases, they are going to give you the full mark. But if your case carries the possibility of 2 or 3 different differential diagnoses, they may need from you to give them other 2 or 3 differential diagnoses. Okay. In this case, there was no too much positive data, so the diagnosis was clear. It is optic neuritis. This is optic neuritis. Yes.
Temporal, sir, I want to exclude the giant cell arthritis or temporal arthritis by facial pain or just chewing. The pain is there, so there's no positive finding.
Yeah.
So there's no positive finding.
No positive finding for giant cell arthritis. And giant cell arthritis, usually the headache on the temporal aspect, it is not behind the eye. In addition to that, the visual loss itself, it will not be, they will not be a color differentiation issue. This question, we did not ask it, and it was going to help you to differentiate between the both. Okay. Remember also, giant cell arthritis usually happen in the old patient. It is unlikely to happen in such a young patient. It is usually happening in the patient over 50 and sometimes 60 years old. Okay, so it is unlikely to be giant cell arthritis or giant cell arthritis. Sorry. Okay.
Okay, sir. Okay, sir. So in this case, for optic neuritis, is any cause behind this, sir? I want to exclude anything for optic neuritis, sir.
for optic neuritis, sorry. What do you want?
Any cause behind this? Only optic neuritis, I would say. Any no other differential for multiple sclerosis?
There are many things for optic neuropathy. This is optic neuritis is a part of a collection of disease. We call them optic neuropathy. There are many causes for optic neuropathy. It can include sarcoidosis. It can include Behçet disease. It can include infection. Some infection can cause it, like syphilis. It can cause optic neuropathy. There are many causes: Lyme disease, toxoplasmosis. Okay, but in the exam, I'm not going. Sometimes even toxin like
medication.
methanol, methanol poisoning, ethambutol toxicity. It can cause optic neuritis. If your case in the exam was a patient who
chloroquine.
If your case was chloroquine usually associated with retinopathy rather than optic neuropathy. If your case in the exam was, for example, was a tuberculous patient or history of tuberculosis, is currently taking ethambutol, you can put number 2. The differential is ethambutol toxicity. Okay?
Okay, sir. Thank you, sir.
So remember, in this case, it is MS. Other differential depend on your case in the exam. It could be giant cell arthritis if the patient was an old age. It could be vitamin B12 deficiency in some cases. It could be ethambutol toxicity if the patient is on ethambutol, and so on. Okay.
Okay, sir. Thank you, sir.
Okay. Any question in this case before we proceed into the next case? I'm going to explain, by the way, the proper approach to the headache. What are the differential diagnoses for the headache? How we can approach the headache in a proper way without forgetting any important question. Any question?
Dr. Ala.
Yes, Dr. Leila.
In this case, any dissociation in the time or previous weakness or previous attack?
She had a weakness. She had a weakness 1 year ago back.
Okay.
1 year back, she had an attack of weakness, and she asked me about history of admission. I told her that I was admitted 1 year back in the hospital because I had a weakness over my left arm.
Okay, I didn't hear this part.
Okay, it's okay. Any question, ya shabab? Remember in the exam, optic neuritis.
Assalamu alaikum. The last issue just
yes, Dr. Hani.
Driving.
Yeah, driving is very important. This is very nice, very nice point, Dr. Hani. You have to ask about the driving. Any patient with visual disturbance, you have to ask him to stop the driving and inform the DVLA. This is very important. Okay? Okay, Dr. Irene, but you forget the whole social history. The whole social history.
Actually, for my slowness, my time consumed, so that I have to fast. Yes, sir.
Yeah, just try to increase your tempo, increase your way of approaching the case, ask the question in more fastest way, and in faster way, sorry, and you are going to reach to that. You are so close, almost there, but I think you did not find the time to ask all the other relevant questions. Okay, this is optic neuritis. Remember, in the exam, optic neuritis, they can present the case to you with visual disturbance, or they can present the case to you with headache. The headache in optic neuritis, usually it is behind the eye. 90% of the patient, they have a headache or a pain behind their eye. Okay, periauricular pain, headache in form of a pain behind the eye. Okay. Other causes of pain behind the eye, it could be also cluster headache. Okay, but cluster headache usually came in attack lasting from 15 minutes up to 2 hours, in addition to the redness of the eye, the tearing of the eye, the nasal stiffness. One of your colleagues mentioned that we have to ask about the other question, and she was right. Any question in this case? Any question in this case before we proceed to the next case? If no question, we are going to Dr. Omima, you want to say something?
Yes, doctor. My question was about the examination. Is it enough to do like a quick neurological examination, tone, power, reflex, and the eye movement? Anything else?
Depend on your case in the exam. This case, you have to start with the visual acuity, number one. Number two, you have to offer fundoscopy, because as we said, in some cases, you may find that there is a swallowing in the optic disc. This is something very difficult to detect it by the PACES candidate. It is not our level to detect the swelling in the optic disc. And by the way, it is not positive in all the cases of optic neuritis. It is only positive in 30 to 40% of the cases. The third thing which you have to do it, which is to detect the relative afferent pupillary reflex. This is something you have to alternate the light using the torch, alternating the light between the both. You will put the patient hand between his eyes, and you will move the torch between the both eyes to check the diameter of the pupil. In the patient with the optic neuritis, usually they have a positive relative afferent pupillary defect or reflex. So this could be positive in the patient with MS. After that, if you have a time, you can check the tone in addition to the power and reflex. Usually you can do it in the upper limb if you have a time. Okay? Usually we do it in the upper limb. We use, as I mentioned before in other session, try to do it in the biceps better. Just the reflex here, the power in the biceps, and in addition to the tone. Okay?
Okay. Thank you, doctor.
You're welcome. Yep, one of your colleagues mentioned patient can see nothing and doctor can see nothing. This is typical in the patient with optic neuritis. Okay. Any question before we proceed to the next case? Okay, if no question, I'm going to go into the next case. The second one in the list was Dr. Tenzil. Dr. Tenzil, are you here? I think you are here.
Yes, sir, I'm here.
Dr. Tenzil, I don't know, but I can't hear your voice very well.
No, you can hear me, sir.
I can hear you, but not. Usually, your voice is not that clear for me. So if you can just try slightly raise your voice, and I'm going to give you the second case.
Okay, now I think you can hear me, or I should speak louder.
Yeah, I can hear you. I can hear you.
Okay, thank you, sir.
Hello, excuse me, Dr. Ala. Before starting this case, I want to ask, how can differentiate between optic neuritis and neuromyelitis optica if the patient comes with weakness?
Neuromyelitis optica. Usually, the patient will have an antibody testing in the patient with neuromyelitic opticus. You have to check for antibody, especially serum NMO antibody, especially if the patient has recurrent optic neuritis and the MRI was negative. Okay.
Yes.
Okay, this is by investigation, but by examination, I don't think it is easy for us at the PACES level to detect it, because patients with neuromyelitis optica usually they have recurrent optic neuritis, and they will have an antibody. You have to check for the antibody to check if they have neuromyelitis optica. And by the way, it's one of the differential. Okay.
Yes. Thank you.
Aquaborin for a specific serum autoantibody. This is the antibody for neuromyelitis optica. Another antibody is myelin oligodendrocyte glycoprotein. But I think those things are an extra point, or I think they are slightly above the level of the of the bases. But if you are interested to know them, it's okay. If not, it is up to you.
Okay, thank you, Dr. Ala. Thank
Okay?
you. Thank
You
you.
are welcome. Okay, Dr. Tanzil, can you hear me?
Yes, yes, sir, I'm hearing you.
Okay, the second case is, let me check my list. Again, the same advice. We are here just to practice. You are the one who is going to remember your mistakes and your defects. No one after this session is going to remember you. So just write down all the comments from me and from your colleague. And this is going to help you to master Station 5 and improve your performance, okay?
Inshallah.
Okay. Okay, female. 21 years old, presented with headache.
Okay, sir.
Okay, 1 minute and we are going to start. Okay, just 1 minute.
1 minute? Okay.
1 minute.
Okay.
Female, 20 years old, presented with headache.
So can we start?
Yeah, we can start. 3, 2, 1, let's go.
Hello, good morning, Mrs. Sarah.
Good morning, doctor.
I'm Dr. Bukhari and I'm here to talk to you and examine you. Is it fine?
It's okay with me, doctor.
So may I know what brings you to the hospital today?
Well, over the last 2 months, doctor, I have this headache, doctor. I took a lot of medication for it, but it keeps coming and going, doctor.
Well, I'm sorry to know this, Mrs. Sarah, but don't worry. We're here to help you out today.
Okay, thank you, doctor.
So how it started suddenly or gradually?
Well, it's gradually, doctor.
When was the last attack?
I think 2 days ago. I have this headache, and today also I have this headache.
Where exactly you feel pain in your head?
Well, all over my head, doctor.
So if I ask you to grade it from 1 to 10, 1 being the mild and 10 being the severest, how much will you grade it?
I think I can give it 3 or 4, doctor.
And how it sounds to you, like gripping, pinching, throbbing?
Well, it is dull, doctor.
Like a band-like pain all around your head?
Yeah, sometimes it's like a band all over my head.
And does it go anywhere else, like down to your neck or to your shoulders?
No, doctor.
What makes it worse?
Well, nothing, doctor. Nothing specific.
Any effect of coughing, sneezing, bending forward?
No, doctor.
Anything that makes it better?
Sometime when I took this paracetamol tabs, doctor, I feel a little bit better. Yes, doctor. Dr. Tanzil. Okay, we are going to stop. Yeah. Where did you?
Can you hear me?
Yeah.
So anything that makes it better?
No, doctor. Sometime I told you I took some tabs, paracetamol tabs. I took it from my GP. It helped me a little bit.
Well, Ms. Sarah, any problem with your vision?
No, doctor.
Any weakness in your arms or legs?
No, doctor.
Any difficulty controlling your waterworks or bowel works?
No, doctor.
What was your weight, Mrs. Sarah?
My weight? Not changed over my weight, doctor.
Right. Any problem with your waterworks? Like any frothy urine or any repeated burning waterworks?
No, no.
Any pain in your tummy?
No.
Right. Do you feel any unusual things before the headache?
Unusual? No, no, no.
Like,
no, doctor.
Right. Any disease that runs in the family?
No, doctor.
Any history of any strokes or any strokes in the family?
No.
Any kidney problems in the family?
No, doctor.
Right.
But my mother has been diagnosed with migraine, doctor. She had this headache also that keep coming and going also over the last 1 year, and I think she is still suffering with this headache, doctor.
Well, I'm sorry to know about your mother. Well, Mrs. Sarah, are you using any medicine?
No, doctor.
Anything over the counter?
No, doctor.
Do you smoke?
Yeah.
How much cigarettes?
I think about 2 cigarettes every 3
Since
days
how
or
long?
4 days. I think for the last 4 years, doctor.
Well, any alcohol intake?
No, doctor. Just over the weekend.
What do you do for living, Mrs. Sarah?
Well, I'm still a student, doctor, in the final year of my college.
How are you doing in studies? I mean, must be a lot of stress.
Yeah, doctor, I have a lot of stress in my college, doctor. But I feel like I don't know, but I feel better when I go to the college, doctor.
Any exams nearby?
No, doctor, no.
Well, what about the sleep, Mrs. Sarah?
Well, it's okay, doctor.
Well, if you don't mind, may I ask you some personal questions?
Okay, doctor. Go ahead.
What about your monthly periods?
My period, it's okay. Normal, doctor.
Are you using any pills?
No, doctor.
Well, Mrs. Sarah, now I'd like to examine you. Is it fine?
Okay.
So do you have any pain at the moment, right now?
No, doctor.
Well, I will be gentle. If you still feel any pain, please let me know.
2 minutes remain, doctor.
So I will like to do quick physical examination, if anything is there, like any in the hands, anything in the eyes, anemia, jaundice.
Normal.
I will like to see any weakness in arms.
No, doctor.
Any weak? I will like to do I will have a fundoscopy and the blood pressure.
Okay, blood pressure is 120/70. Fundoscopy, no need for it. And you have 1 minute remain, doctor.
So, Mr. Sarah, do you have any concern?
Well, doctor, I don't know, but what's wrong? What's wrong with me? What's happening to me, doctor? Why these headaches keep coming and going? Is it migraine?
Well, Mrs. Sarah, after listening to you and examining you, most likely it is not migraine. I have few possibilities in my mind. It can be due to some stresses in your life, which you are having in your college. Sometimes it can result in this sort of headache. And so most likely you don't have migraine.
I don't have what?
Migraine.
Okay.
You have a headache known as tension headache.
Tension headache?
Yeah.
Okay, but surprisingly, doctor, I feel better when I go to the school, doctor. Or sorry, when I go to the college, doctor. From where I will get this tension, doctor?
So, Mrs. Sarah, I mean, where do you sleep in your home? You sleep indoors or where?
Yeah,
where
I sleep indoors, doctor.
With the gas heaters on?
With what?
Gas heaters.
Sorry, your time is finished, Dr. Tanzil. examiner question.
Okay.
What's your diagnosis in this case?
My diagnosis in this case, which I made, is tension headache, but the lady, I couldn't find any tension in her life. But
Okay.
I was, but when she told me that she is going to college and she feels better, I think maybe she has carbon monoxide poisoning due to some gas heating in the room in the night.
Okay. Did you tell the patient about that?
No, I guessed God's idea in the end.
Okay. What's your finding in this case?
On examination, the patient was normal, no finding.
Okay, so how you are going to investigate this patient?
We need to admit this patient and we need to check his carboxyhemoglobin level.
Okay.
First of all, and then we may give him high flow oxygen.
Okay.
And we need to advise her to change her settings in the room, or to turn off the gas heaters, or to open the windows for ventilation.
Okay.
And we also need to ask about anybody sharing the room, because he or the partner will also be affected. If she's sleeping with her mother or anybody else, we should take care of them also.
Okay.
Yes, sir.
What explains the headache in her mother?
Sorry?
What will explain the reason of the headache in her mother?
This because I was trying to find anything like like any tension in her life, but I think I don't really get the
Okay,
scenario.
if the patient did not respond well to the oxygen, any other line of management?
Really, sir, I am not. I'm unaware.
Okay, thank you, doctor.
Thank you.
Okay, Dr. Tanzil, you did very well. This is not an easy case. It's one of the difficult case. You ask about everything, you exclude everything, almost everything. You analyze the headache in a good way. You ask about the other symptoms of the CNS. You ask about almost everything aside from the analysis of the complaint, like the drug history, the social history, the family history, the female history. But I think you forget the past medical history. You did not ask me about if I have any chronic illness, if I have been admitted before. By the way, this patient has been admitted 3 times in the hospital with the same headache, and no conclusive diagnosis was given or was reached at the end. This patient gave you very important information that she feel well when she go to the college. This is mean that her issue is mainly happening when she is at home. In addition, she gave you indirect history about one family member who have another the same issue. Like also he had her mother has a headache, which is uncontrolled headache. Although she was diagnosed with migraine, misdiagnosed with migraine, and her headache is mainly while she is in home. If you ask her more or furtherly, she was going to tell you, I feel like this headache is more at the night. If you ask me about any specific time, I was going to tell you again, I feel this headache more at the night. By the way, sometimes the cause of carbon monoxide poisoning will not be clear. It will be clear if the patient give you a history of dealing with, he is, for example, a worker in a gas station, he is a fireman, okay? Those things will give you a strong hint to the diagnosis. But sometimes, like in this case, the patient himself will not know what is the exact cause behind his carbon monoxide poisoning. They may have a leak. For example, this patient, they have a leak in the gas burner inside their kitchen. They were not aware with that. So this is, by the way, a real scenario. A real case.
Okay? This was very familiar to last year. Very famous.
Especially during the winter period, if they are using any heating machine, or it can be all over the year at any time if there was a leak in the gas burner or the gas oven. So the clue here in this history that this headache occurred at a specific time at a specific place. In addition to other family member has same headache or similar complaint. If you gather all of them together, if you combine all of them together, you can put one of the possibility is carbon monoxide poisoning. Okay, aside from that, you did everything very well. You was able to discuss with me the case. You was able to give me the proper investigation, which is carboxyhemoglobin. All the patient with carbon monoxide poisoning, regardless of the level of carboxyhemoglobin, they have to be admitted to the hospital and they have to be given 100% concentration of oxygen. Sometimes the patient may need hyperbaric oxygen if the level of the carboxyhemoglobin was very high and the patient developed any other neurological feature. In addition, for example, the patient has loss of consciousness, the patient has extrapyramidal feature. Those patients, they may need hyperbaric oxygen, okay? Or if the level of the carboxyhemoglobin was very severe, above 30%, the patient may need carboxyhemoglobin. Okay, the second differential could be tension headache. By the way, when you ask me in the character of the headache, there is no specific or clear character for the patient with carbon monoxide poisoning. It was reported in some patient, it is the character of this headache is similar to the character of the tension headache. It will be band-like all over the head. And the degree or the severity of the headache usually about mild to moderate headache, okay? In the area of 4 to 5, in the area of 5 to 4.
Intensity.
Yeah, 4 to 5.
Intensity.
Yeah.
Intensity. Yeah, okay.
Okay.
Okay, sir.
Welcome.
You asked me a question that if the patient is not improving by oxygen,
we can give hyperbaric oxygen.
Okay,
okay. Okay. If the patient was a child, if she was a pregnant, in the child patient, in the pregnant patient, if the patient has a loss of consciousness, if the patient has any abnormal neurological finding, like deterioration in the mental status, if the patient has prolonged exposure, he was exposed to the carbon monoxide for more than 24 hours. If the patient developed any cardiovascular symptoms or dysfunctions, like patient with tachycardia, palpitation, all those cases, they need hyperbaric oxygen. Okay?
Right. Okay, sir. Thank you very much.
You are welcome. We use usually we use one of the doctor mentioned here, there is a difference between smoker and non-smoker. Yes, the difference in smoker and non-smoker, for how long you are going to continue giving the oxygen. Usually, if the patient is non-smoker, if the patient is a smoker, till the level of carboxyhemoglobin reach below 10%. Okay, doctor? But if the patient is non-smoker, you have to give him the oxygen for more period, more prolonged period of treatment, more duration. The duration of treatment will be more longer in a patient who are not a smoker. You have to give them the oxygen till the level of carboxyhemoglobin below 3 or 4%. But those details, I think they are also again above the level of the basis level, and I don't think that the examiner will have a time to ask you about those questions. Okay, remember this exam is not about the knowledge. They have tested your knowledge already in part 1 and part 2. If you already passed part 2, in the PACES, they are trying the other skills. They are trying to assess other skills, and we already know, all of us know that the other skills that you are going to be tested on in the PACES exam.
Dr. Ala?
Yes, doctor?
Can you kindly re-summarize the management of carbon monoxide poisoning management?
Okay, management, the best investigation in this patient we have to do for them, number 1, the carboxyhemoglobin. This is very important. Okay, and all of the patient, all of them, you have to admit them, and you have to give them 100% oxygen. Okay. For how long you are going to give the oxygen? This is something what is the duration, or for how long you are going to give them the oxygen? This is something, as I told you already, it is something above the level of the PACES. But if you want to know it, if the patient was a smoker, till the level of carboxyhemoglobin become less than 10%. If the patient is non-smoker, you have to continue and give them the oxygen for prolonged period, which is till the level of carboxyhemoglobin become less than 3%, 3 or less than that. Okay. There is some patient who will have severe symptoms of carboxyhemoglobin, severe toxicity. Those patients usually we give them, we put them in a special machine, and they will give them hyperbaric oxygen. This hyperbaric oxygen, the indication for it, again, this is something, if you want to know it, it's up to you. If you don't want to know it, you can just ignore it. If the examiner asks you what are the indications for hyperbaric oxygen, tell him if the patient has a loss of consciousness, if the patient has any abnormal neurological finding, if the patient was pregnant, if the patient was a child, if the exposure itself for the carboxyhemoglobin was for more than 24 hours, if the patient developed any cardiovascular symptoms, those patients need to be given carboxyhemoglobin. Hyperbaric oxygen. Hyperbaric oxygen. They have to be put, you have to place the patient in all the pregnant patients. You have to place them in the hyperbaric oxygen chamber, which is not available in most of the hospital. I think it's available only in highly developed or very developed hospital. Beyond the level of tertiary hospital. Okay? Or highly specialized hospital, sorry. Yes, Dr. Rasheza?
Sir, I have one question.
Okay. Okay, Dr. Tanzil.
I usually, when I analyze pain, I don't ask about time and place. So do you think in headache we should
in headache it's important. In headache it's important because you already put in your mind one of the differential is carbon monoxide poisoning. By the way, carbon monoxide poisoning, the scenario of carbon monoxide poisoning is not appearing in the overseas center. Usually appear in UK center. Till now, I don't know that if it's ever appeared in one of the overseas center. It usually appeared in all the previous experience of the cases of carbon monoxide poisoning was in UK. Okay, where in UK?
Okay, thank you.
Okay,
examination?
Examination, you have to examine the tone, power, and reflex in this patient. Okay, because any headache is a neurological examination. You have to examine the tone, power, and reflex. Start with the biceps. Just check the biceps, the tone in the biceps, check the tone in the biceps, check the power in the biceps, check the reflex in the biceps. If you have a time, you can check the knee joint or the knee, at the knee joint, you can check the tone, power, and reflex at that level. Okay, or you can check also the pronator drift if you like. In addition to the general examination, similar to the pulse, similar to the eyes.
Okay.
Okay.
Sorry, Dr. Ala, is it logic for a home to have carbon monoxide leak for months or for years? Or like?
Yeah. This is a real case, by the way. This is a real case. It is not. It is not just a case from my mind. I created or I invented. This is a real case. A case report. I can share it with you after the session finished, inshallah, Dr. Said. Okay. By the way, our approach for the headache usually cover the carbon monoxide poisoning. It will cover the carbon monoxide poisoning. Depression is low mood. How can I exclude depression? How can I exclude depression? Sorry. You mean the tension? The tension, doctor? The tension or the tension headache, you mean? Tension headache, he already asked. He asked if he feel like I have a low mood from study. I told you no, I don't have any tension in my life. He asked me about if I have an exam in the future or recent exam. I told him no. So all those questions can preclude or exclude for you the diagnosis of tension headache. You can ask clearly about the mood. How is your mood? Do you have do you feel like your mood is low? Do you feel very anxious? Do you have anything in your life make you very anxious or depressed or upset? Clear question, straightforward. And he already asked those questions. Okay, any question in carbon monoxide poisoning? Any question in this case?
Sir, neurologically, when I examine the tone power difference, is there any finding for carbon monoxide poisoning?
No. Unless it's a severe case, usually you will not find any finding in this case.
Okay, sir.
You can find hyperreflexia. Hyperreflexia can be present. It can be present, but in the other patient. If the patient with severe
bounding pulse, monkey.
Bounding pulse, it could be, but all those findings usually in the severe and advanced cases. And in the exam, if they bring a case for you with carbon monoxide poisoning, they will not bring a case for you who's supposed to be admitted. Okay, the feature of any cardiovascular feature like arrhythmias and the hyperreflexia in the CNS, the extrapyramidal symptom, this means that the toxicity level is very high, above 30%. This patient is supposed to be under oxygen, and if he was in highly specialized hospital, he was going to be transferred to hyperbaric oxygen chamber. So don't expect in the exam to get such a case. Okay.
Okay, sir.
Okay.
You mean mostly it will be surrogate, no findings at all?
Yeah, mostly it will be a surrogate.
Okay, sir. Thank you.
Okay. Any question again?
Again, Doctor Ala.
Yes,
what is the system? The system are going to examine patient of headache.
Patient of headache usually CNS in addition to the general. You have to examine the tone, power, reflex in addition to the general examination. General appearance of the patient, ask for the blood pressure, examine the pulse, check the hand, and you have to examine. In the hand, you may find if the patient was a smoker, although smoking is not one of the predisposing factor for the patient. It can affect the prognosis, but it cannot. It is not one of the clear factors that will lead to carbon monoxide poisoning. You can check the nicotine staining, and you have to examine the eyes in addition to the tone, power, and reflex. Okay. Usually in this case in the exam, you will be a surrogate, so there will be no mark. There will be no mark on the examination. Similar to the cases of station 5, where they bring for you a surrogate, you will just offer to examine. The examiner will let you do all the examination, but there will be no mark on the examination.
No mark in the examination?
No mark, but you have to offer. You have to offer for the, I would like to check the tone, I would like to check the power, I would like to check the reflex, I would like to check the pulse, examine the hand, look at the eyes. He may stop you from continuing the examination, and we'll discuss the, he may not be caring about what you are going to do, or he may stop you from those things. If you stop you are going to jump into the next step, which is a concern. Okay. In such a case, if the patient was a surrogate in the exam, expect that the patient will have a lot of concern. He, for example, will not just ask you about what do I have, doctor. He may ask you another question. Is it migraine? Is it because of the pills that I'm taking? If she was taking oral contraceptive pills, and so on.
He will consume the time, however.
Yeah, he will consume the time because there is no finding in the examination. Okay, any question? Any question, ya shabab? Any question before we proceed into the next case?
Excuse me, sir. Is there any contraindication of hyperbaric oxygen?
Sorry, Dr. Hussein, I couldn't hear you. What did you say?
Is there any absolute contraindication for the hyperbaric oxygen?
Any absolute contraindication for
hyperbaric oxygen?
Well, I am not sure about contraindication. I'm sure about the indication.
Okay, okay.
If there is a contraindication, actually, I'm not sure about that, because even this form of treatment, you cannot find it in any hospital. Even in tertiary hospital, it is not just available because it is a highly expensive chamber, usually available at the burn unit. The hospital, which they have a highly specialized burn unit, they have those kind of machine and chambers. Okay, so I'm not really sure about the contraindication. I'm sure about the indication for hyperbaric oxygen.
Okay, but if the patient has unpaid pneumothorax, then it is the contraindication that lead to the tension pneumothorax.
Pneumothorax? I'm not sure.
Yes.
Actually, Dr. Hussein, I'm not sure. I'm not sure about that.
Okay, thank you.
Okay, you are welcome. Thank you. But I can check it for you later on, and if I find something useful, I can share it with you. Okay,
thank you, sir. Thank you.
Welcome. Okay, so we are going to stop here just for the prayer time, and we are going to come back after 15 minutes. Okay, 15 minutes, 5:35. We are going to continue our session, and the next case will be the case for Dr. Sayed. Please, after the break, be sure to be here. Okay?
Okay, بعد after صلاة إن شاء الله.
15 minutes. 15 minutes is enough يا شباب. I'm not sure والله which time zone is
لا
now.
not enough دكتور.
Not enough?
Not enough.
How
because
long?
صلاة didn't start yet.
والله even for me, the prayer here after 1 hour, after almost 1 hour from now. But I'm not sure, I don't know where is this time zone. Anyway, if one of your colleagues requests something like that, we should stop. Okay, 15 minutes, then we are going to continue. Okay? Okay. Thank you, everyone. Let's meet after 15 minutes to continue this session.